Print servers in federal environments create risk and unnecessary complexity. Every new printer, location, or policy adds strain to infrastructure that was never built for today's demands. FedRAMP High Authorized Printer Logic eliminates print servers with a secure cloud-native, zero-trust solution designed for federal IT. With advanced security, centralized control, and simplified management, agencies can modernize print without added burden. See what secure serverless printing looks like. Visit Vasion.com to learn more.
Federal Drive is presented by GEHA, Government Employees Health Association, proudly providing health and dental benefits to federal employees and their families. Visit GEHA.com.
The HHS Office of Inspector General is seeking public input on how fraud and abuse laws affect payments to clinical trial participants. The effort could help determine whether existing rules strike the right balance between protecting patients and supporting medical research. Joining me now is Spencer Turnbull, Chief of the Industry Guidance Branch at HHS-OIG. Spencer, thank you so much for joining me today.
Thank you for having me, Terry. I'm very happy to be here.
Your office recently put out a request for information on payments to clinical trial participants. That's an interesting topic and one probably that most people don't talk about very often. But what is it about what's going on now that is of interest to you, and why are you taking a fresh look at the issue?
We issued this request for information, or RFI, because we want to improve our understanding of how clinical trials are providing remuneration to trial participants, and to learn whether the federal anti-kickback statute is viewed as a barrier to providing appropriate remuneration to those participants. For us, getting curious and posing questions to our stakeholders is one of the most effective ways for my office, which is the Office of Inspector General for the Department of Health and Human Services, HHS-OIG, to fulfill our role in considering new safe harbors under the kickback statute. And if I might, Terry, I know I've used at least 3 technical sounding terms, and I would love to briefly explain what each of them means for our listeners who might not be steeped in healthcare law. Would that be okay with you?
Please do that. I have some questions myself. So you go with your definitions and we'll see if anything else is left on my list.
Great. Well, these are really at the heart of the RFI that we're discussing. You might know that HHS-OIG is at the forefront of America's efforts to fight waste, fraud, and abuse in HHS programs. But you may not have heard of the federal anti-kickback statute. I might just call it the kickback statute for short, but this is one of HHS-OIG's most powerful tools to deter and prosecute fraud. The kickback statute is a criminal law, and it prohibits the knowing and willful payment of remuneration, that's anything of value, to induce or reward referrals of federal healthcare program business. And that means things like prescription drugs, medical supplies, or healthcare services for Medicare or Medicaid patients. You know, in some industries, it's acceptable to reward those who refer business to you, but healthcare paid for with our tax dollars is another matter. So imagine you are sick and you go to your doctor who tells you that you need a prescription. Now imagine that a drug manufacturer has promised to give your doctor expensive concert tickets for every 50 scripts he writes for their drug. Will your doctor be prescribing you the drug that's in your clinical best interest, or the drug that will earn him concert tickets? So the kickback statute stands guard against that kind of corruption of medical decision-making. I also use the word remuneration a couple of times. In the kickback statute, that just means anything of value. It could be cash, it could be something like free rent or expensive meals or excessive compensation. And here in the clinical trial context, it could mean help with someone's copayments or a travel reimbursement. So the last term I wanted to touch on is safe harbor, which is, again, at the core of the RFI we are discussing. A safe harbor under the kickback statute protects certain payment and business practices from kickback liability, where that practice could otherwise implicate the statute. Safe harbors are voluntary. Their provisions have been developed to limit the reach of the kickback statute by permitting certain non-abusive arrangements while encouraging beneficial or innocuous arrangements. And that sort of brings us back to this RFI, which is seeking feedback from our stakeholders on whether a safe harbor for clinical trial remuneration is needed, and if so, what such a safe harbor should protect.
That was hugely helpful, and you ticked off all 3 definitions I wanted to follow up on, so thank you for that. But now let's talk about a safe harbor. What would that actually look like if you were going to put it into place?
That's a great question, and it's really at the heart of this request for information. OIG doesn't know the answer yet, but we want to find out by hearing from clinical trial stakeholders, and besides asking the public to weigh in on that particular question of what one might look like, we also want to ask and have asked some related questions, including what are the types and amounts of remuneration that are currently being provided to trial participants, and what types of remuneration would folks like to provide that maybe they're not sure whether they can. We'd also like to know about some of the fraud and abuse risks that might be associated with providing remuneration to participants, and people's ideas for safeguards that are necessary or prudent to prevent fraud and abuse when participants are receiving remuneration.
Spencer Turnbull is the chief of the Industry Guidance Branch at the U.S. Department of Health and Human Services Office of the Inspector General. So, Spencer, if we step back now from the details of specific arrangements, it seems like at the simplest level, maybe you're weighing two concerns. On the one hand, researchers want to make participation easier and they want to get people in the door. On the other, regulators don't want financial incentives driving medical decisions. So where do you and the OIG sit and evaluate that balance? How do you know if it's shifted too far in one direction or the other?
Terry, that's such a great critical question for the work that we do. In the context of the RFI, I can speak to OIG's general approach when developing new safe harbors for the anti-kickback statute. Writing an effective safe harbor begins with understanding the landscape of the issue it purports to address. And it would be a missed opportunity to create a safe harbor that doesn't get used because it doesn't reflect the reality of conducting clinical trials. That's why we're soliciting feedback from stakeholders on several different facets of remuneration provided to clinical trial participants. Questions like the benefits of enrolling federal healthcare program beneficiaries in particular into clinical trials. What are the barriers to enrollment that trial sponsors are facing? And what are the types of remuneration that are effective? What are the risks that must be managed, et cetera? So were OIG to decide to draft a proposed safe harbor, we would be balancing benefits against risks, as you noted, asking questions like, would the arrangements protected by the new safe harbor increase or decrease access to healthcare services? Would they increase or decrease quality of healthcare services? Increase or decrease patient freedom of choice or costs to federal healthcare programs? So those are just a few examples of the lenses through which we consider potential new safe harbors and how we conduct that balance.
And is there a concern in this kind of situation that if the payments become too generous, they might actually affect the research by influencing who participates in the study, how the study is conducted, or why people participate in the first place?
Well, that is actually outside the scope of our RFI. But what I can tell you is that OIG will focus on our responsibility, which is to carefully evaluate the need for new safe harbors to the kickback statute and to carefully craft any new safe harbors to protect beneficial arrangements that pose a low risk of fraud and abuse.
And comments on your request for information are due by August 24th. What kind of information would be most useful for you as you're looking for evidence that supports one side or the other here?
Well, I hope that commenters will provide real-world examples, data, and of course, their perspectives that illustrate how payment practices are functioning today. We're especially interested in areas where clarity, a new safe harbor, or a modification to existing regulations could support responsible research participation while maintaining strong protections against fraud and abuse. So, depending on what we learn, potential next steps could include updated guidance, rulemaking, or other efforts to modernize how fraud and abuse frameworks apply in clinical research.
As industry folks might be responding to this, is there a tension between what they want to communicate to you so that the safe harbor rules get written effectively and what they might sort of be confessing in that process?
Of course, I can't speak for how our commenters approach the RFI, but based on our experience, RFIs usually generate candid, useful information. And of course, we'll consider everything that we receive and are grateful for those submissions.
Spencer Turnbull is the chief of the Industry Guidance Branch at the U.S. Department of Health and Human Services Office of the Inspector General. Thanks so much for joining me today.
Terry, it's been a pleasure. Thank you for having me.
We'll post this interview at federalnewsnetwork.com/Federal Drive. Listen to the Federal Drive on your schedule. Subscribe wherever you get your podcasts.